think from my last understanding that, eyelid skin cancers represent about 5 to 10% of overall skin cancers. And given that there's such a small surface area off the body, that's quite a lot. Most commonly, about 90% of them are basal cell carcinomas, which are probably the safest type of skin cancer to have. But there's also squamous cell carcinomas and even melanomas, which are much rarer, but do happen on the eyelids, and we do see them. Very common in sun-exposed countries like Australia. And I think traditionally we're all taught, slip, slop, slap when I grew up in the 80s, and that was all over. But people are worried about putting creams and things near the lids. So I guess, if you do have a lesion or concern, it's really important that you do seek advice about that or something that you don't think is right.
So what are the warning signs that someone should look for? Is it usually like visually obvious if somebody has a lesion?
Yeah, look, it may not be obvious. It might look, it's sometimes it's an overcall. It might just be a small elevated lesion, and they're quite common to get little cysts on the eyelids that
Mm.
are benign. It could be flat or slightly elevated. Often it's a non-healing lesion, so something goes away is not usually malignant if it's, or getting smaller, if it's persisting, despite maybe using some moisturizer in case it's a bit of eczema or dried skin, or if there's a change in symptoms, so it starts itching or bleeding or changing color or texture compared to the surrounding skin, if it gets smoother or little red blood vessels on the surface. Or if you lose the little hairs over there, so it's close to the lashes, sometimes people lose eyelashes, or it's further down the face, just the vellus hairs like the ones we get on the inside of our arm, the baby hairs. If they kind of go missing and it's smoother, that could be, an odd feeling that something's going on. And other rarer findings, but people don't really know about this, is what we call formication, which is a feeling of ants crawling on the skin. So if a lesion has actually been missed surface wise and has grown deeper, it can cause weird feelings and sensation if it's infiltrated a nerve. And often patients have had some cryotherapy done by the GP or been treated by Effudex or Adara, which are these topical treatments that cause inflammation and get rid of surface pre-malignant lesions. But something microscopically might have been left behind and it's grown deeper and you can't see it on the surface. So if you get some weird feelings like that, it's worth coming in for a look.
So, you hear a lot about people should go in see their dermatologist or their local doctor to get their body checked out for, moles and spots and that sort of thing. I did that last year and got a clean bill of health, thank God.
Well done.
But is that something that like eyelid lesions something that your local dermatologist or GP could pick up, or does it really does it really need to be done by an ophthalmologist like yourself?
So I think exactly what you said can be picked up by your GP or dermatologist. I have no issue with them diagnosing and detecting, and in fact, we rely on them to do that. Often they will do the first step for us, which is fabulous if they do a little biopsy, but my preference is that they do what we call an incisional biopsy, where they preferably photographed it before interfering with the lesion so that I can maybe see what it looked like before, even on the patient's phone. And, if you're going to see a doctor, it's good to have evidence of what it looked like before it's been interfered with, because sometimes the biopsy will heal it nicely. It's really hard to see where and what it looked like before, especially when it comes back as a basal cell carcinoma margins involved or something like that. So it's good to both have that photographic evidence and the biopsy report. But if not, then when they come and see me, I would do an incisional biopsy, meaning I don't want to interfere with the margins, so I can go back and find exactly where it was before. And when I want to go take it out later, I will take some margins, but I would do a piece from within there and send it away, and they will tell us what it is if I'm suspicious that this is something concerning. Otherwise, sometimes we just monitor, or if it's something I think is benign, we can just take it off, or the GP can take it off. But occasionally we get surprised by the results.
So that's the diagnosis stage. So I guess the big question which a lot of people would have is like, what does treatment actually involve, and what's the recovery process like?
Yeah, so like I mentioned, I do want the margins ideally untouched. So if it comes back as saying it's malignant, then, whether it was me or someone else who did that initial stage, the excision would involve a margin. So what that means is we would take the patient, lie them down, put a pen around the lesion and add maybe a 2 millimeter, or depending on the cancer, sometimes a larger margin. And we send that specimen to the pathologist who might be next to us as a frozen section or in a laboratory, and they will look at the margins and generally will mark them with some sutures so that they know what 12 o'clock and 3 o'clock is, or whatever, you'll mark it around a clock face sort of thing. And then they will tell us, you've got it all. Great. Okay. Or no, your deep margin or one of your radial margins, say at 2 o'clock, you've left a little bit, it's touching the margin there. And then at that point, we'd go back another time and take another frill of tissue at that area and again mark it up and have it cleared, ideally before we go back and do the repair process, which is a reconstruction of whatever layers of the eyelid plus or minus tear duct system have been sacrificed at the time of excision surgery. So obviously the earlier you get it, the less removal of important eyelid tissue and less reconstruction may need to be undergone.
So is this something that would require an overnight stay in a hospital then?
Generally, most of my surgery is not an overnight stay, like unless it's an orbital tumor or something like that, and deep, and we want to monitor the vision. Most surgery of the eyelids that we've talked about today is a day surgery stay. So you would have a sedation and the carer would come and collect you, meaning an adult over 18 who's responsible. And then you go home, and be seen as an outpatient appointment, often 1 to 2 weeks later for suture removal.
And I'm guessing, like most medical conditions, the earlier it's diagnosed and the earlier that management begins, the better the outcomes are likely to be. Would that be fair to say?
Yeah, I mean, the smaller the surgery, therefore less recovery time and also less critical tissues removed. I mean, sometimes if it's, say, half of a lower lid, and we don't see this uncommonly, and you add a margin, or even if it's just under half and you add a margin, you end up removing really important critical tissue where you can't just repair it by moving tissue locally, and you have to use the upper lid to reconstruct the lower lid, keep the eyelids hinged by a flap to grow a new blood flow in, and divide it up 4 weeks later. And that's a lot of downtime for a patient. And then they're missing a row of lashes in the lower lid. It does heal pretty well, and most patients are surprised by how well it heals and looks afterwards. And most people, they say, oh, people don't really notice it, which is great. But obviously it would have been better if it was a smaller thing in the first place and they had less of a surgical procedure and less of a abnormal appearance potentially with that reconstruction.